Ready to, Dr. Kirsch is from UCSF, and we're going to learn about MEG scans and how we can get better surgical outcomes from that. Take it away, Doc.
Great. I am going to set up some screen sharing here. Is it enabled? It's enabled for everyone here. So let me just set up my slides and we'll get going. Thank you. There you go. Are you able to see my slides okay? Great. I'm going to assume that everyone's okay. If anyone has a problem seeing, feel free to unmute and let me know. So good afternoon and thank you for the invitation to speak today. And I'm Heidi Kirsch. I'm an adult epileptologist. That's a neurologist who specializes in the treatment of epilepsy. And I'm here in my capacity as the clinical director of the MEG lab at UCSF, and we're also known as the UCSF Biomagnetic Imaging Lab. And by way of disclosure, I wanted to let you guys know that I've also worked with and am part of an institutional research grant for RICO. I see we have Amy for RICO here, and RICO is a manufacturer of new MEG systems. So I wanted to disclose that we're in a very productive partnership with RICO, although I won't be discussing our specific work together today. And before we get started, I just wanted to give you a brief roadmap for what I'll be talking about today. And the first thing I'd like to share is just what is MEG. I hope to give you some insight into what we mean when we say MEG or MEG. And then I'm going to be talking about why your doctor might want to order an MEG, what they might be looking for when they order that test. And then when you're getting ready to go to the MEG lab, what to expect when you're preparing to go into the lab. Then I'd like to share a little bit about what's new, what we're developing in the lab, just to whet your appetite. And then at the end, we'll have about 10 or 15 minutes for questions. So if you think of any questions along the way, if you want to pick up a pencil, your phone, and just jot a couple notes, then we can come back to them at the end. And I think somebody's monitoring the chat as well. So we can get back and hopefully you'll get a chance to answer anything that comes up during the presentation. So to get started, what is MEG? Well, the answer is really in the name. If you break it down, it's a long name, magnetoencephalography. So let's break it down a bit. So the magneto part has to do with magnets. So we're starting to think about magnets and magnetic fields. And then encephalo, what does that mean? That really means that we're thinking about the brain. That's Greek for brain. So encephalo means brain, and gram actually relates to writing. So when you put the words together, magnetoencephalogram, it's what it is magnetic brain writing or recording. In other words, it's a recording of the brain's magnetic activity. So that's all it is. MEG detects tiny magnetic fields that are produced by brain cells in the cortex, which is the outer layer, the gray matter of the brain. And the magnetic fields can show us both abnormal activity produced by the brain, like in a spot where seizures might begin. And it can also show us normal activity that's produced by the brain while you're just hanging out and thinking, or when you're doing a task like listening or speaking or writing or playing video games, pushing buttons. And this activity can be analyzed and used to produce a map or an MSI, a magnetic source imaging, that your epileptologist and your neurosurgeon can use for pre-surgical planning. So that's what an MEG is. When we say MEG, that's what we're talking about. So often when people hear that they're getting a MEG, they say, is it like an MRI? Because they hear about magnets and they hear about a brain scan. And it's not really like an MRI. MEG just listens to your brain while you hang out. the scanner does not emit a magnetic field or any radiation. It's not noisy. You're not lying in a tube, and you can sleep for most of it. So it's a pretty low-key exam, and it's quite different from an MRI. Although we do merge the results with your MRI to give us that brain map in the end. MRI shows your brain anatomy, and the MEG shows the function of what's going on with your brain while you're using it. So they're different in that way as well. So the next thing, I had an EEG to look at my brain waves. How is MEG different? Actually, MEG is pretty closely related. If you think about an EEG and how it works, an EEG also looks at brain waves. And brain waves while you're hooked up to the EEG. It can't really look back in the past and tell you about what happened in the past. But it has a pretty good ability to tell what's happening during the test itself. And EEG can record both normal brain activity, and hopefully it can pick up any abnormal activity that occurs during the test. And by abnormal, I mean spikes like this, which are a signal of any activity near a region that could be responsible for seizures. So you'll hear your epilepsy doctor talk about looking for spikes as well as seizures. So I'm just going to take a brief digression to talk a little bit about recording brain activity. I think this is really cool discussion that I found on the site called Backyard Brains. So if you want to learn more about how the brain works, this is a really cool site, and it has some neuroscience experiments that you can do at home. And this was a cool one. And it has some great pictures by a Brazilian artist, Italo Moraski, and a really good description that I'm going to read from. I've edited the description a little to make it fit us a little bit better, but I thought it was a really nice metaphor. And the author likens the neurons in the brain to fans sitting in a soccer stadium. So each fan is like a neuron, and the EEG is like a reporter standing outside the stadium with a microphone. That's an EEG electrode, trying to record the noise from the fans inside, and that's the brain activity. So that's the analogy, and I think it's a pretty good one. So what the author said is, often when you are intensely concentrating, many neurons in your brain are calculating many different things. The information capacity of your brain is high, with many different conversations occurring between neurons. And this is reflected here by all of the fans just chatting to each other, blah, 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 blah. This shows up in the EEG as a very weak signal. It's difficult to extract meaning from. Imagine a stadium during halftime where everyone is having conversations between themselves. If you're outside the stadium, all you hear is a formless hum of noise. There are many interesting things being said, probably, but you can't detect it outside the stadium. So that's similar to what we call background EEG. While you're just sitting around and thinking, and we have EEG electrodes, we see a rich babble, just sort of random brain waves made up of all your different activity. And we can't really distinguish what you're thinking, which is a very good thing for your privacy. So imagine when all the participants in the stadium are doing the same things, such as singing a national anthem. We can certainly hear the song, though it's a little bit distorted outside the stadium. This is analogous to the slow waves when you fall asleep, or the alpha waves that the visual cortex generates when your eyes are closed. So it's a group of neurons acting synchronously to do something together. And you can kind of detect that outside because they're working together doing one thing. You can kind of hear that anthem. The loudest event that we can detect outside the stadium is when a goal occurs. As a huge population inside the stadium all scream very loudly at exactly the same time, goal! When large populations of neurons in your brain do this, all firing action potentials at the same time, it's a seizure. It's a seizure. And I don't need to tell you guys what a seizure is like because you live it every day. So that's the analogy. All of the fans synchronously screaming at the same time. It disrupts all of the conversation. It disrupts everything else that's going on inside the stadium. And you can easily hear that scream outside of the stadium. It's a big synchronous activity from the neurons. Now, with both the singing the national anthem activity and the goal event, we can say that people in the stadium are really synchronized, but they're not, the information is not very rich. It's sort of a low information state. And we can observe similar synchrony in the brain pretty routinely during EEG or MEG recording. We just look at the electrodes in the back of the head and we have someone close their eyes. And when your eyes are closed, there's not much information getting to the back part of the brain that records visual activity. The neurons in the back of the brain all say, it's dark, it's dark, it's dark, it's dark. And not much new information is getting sent back there. And what results, the visual cortex enters the state of synchrony, and it's called alpha rhythm. And you can observe that in a normal EEG or MEG background. So it's interesting because the relationship between this synchrony and data processing in the brain is kind of complicated to understand. But in general, the more synchronous the neurons in your brain are acting, the less data processing is occurring, which is not intuitively obvious, but it leads to interesting effects. If you look at brain waves and they look kind of random and low amplitude, as a scientist here is saying, relax, he's at full attention and working. But if they're synchronous and high amplitude and patterned, that often means that all the neurons in the area are firing at the same time and synchronously. And as you know, this can mean a seizure. This can lead to the symptoms of a seizure, whether that means loss of awareness or whether that means a convulsion. So that was just a digression, but I thought it was useful to understand how these signals can add up and lead to something that we can see external to the skull on EEG. So EEG can record both normal activity, which is this sort of asynchronous chatter that's going on all the time, but it can also record abnormal activity like these big synchronous spikes or seizures. And so how is MEG different? Well, instead of recording electrical activity produced by the brain, MEG looks at the same activity, but it looks at the tiny magnetic fields that this very same activity produces. So this is a little surprising. I mean, who knew that your brain was generating its own magnetic field? It does. Your brain makes its own magnetic field. It's making it all the time while you're thinking. So while you're thinking, your nerve cells are acting as tiny magnets. There's current flow along the dendrites of your nerve cells. And these nerve cells are all lined up along the surface of the cortex in the brain here. And with so many nerve cells all lined up in the same direction, together, the current generates a magnetic field that's perpendicular to that current. So you end up with these tiny little magnetic fields. And when I say tiny, I mean really tiny, 10 to the minus 12 Tesla. This is 1,000,000 times weaker than the field of the planet, 1,000 times weaker than the magnetic noise that we get when a car or a train goes by the MEG lab. So they're very interesting, and they have a lot of physical properties that make them very attractive to us that I'll talk about later, but they're actually pretty hard to record. So in order to record them, we need to put these tiny, very sensitive sensors called SQUIDs, superconducting quantum interference devices, around the head. And at least nowadays, they're inventing newer ways of keeping these things working, but for now they need to be kept super cooled using liquid helium. So we need very sensitive devices, and we also need to perform MEG with shielding around the person having the test so that these external magnetic fields don't interfere with our recording. So I'll show you a picture. The very first MEG recorded, it was by David Cohen at MIT in 1971, and he recorded MEG, and he only had one sensor, one of these sensors, and he recorded from the back of the head of his subject. I don't know who his subject was, I should look that up, but he's recording from that visual region of the brain, and he has one channel, one sensor, and you can see here that he's recording the visual cortex, he's recording the chattering, sort of the random brain waves, and then he asked his subject to please close his eyes, and we see this synchronous alpha activity that we were just talking about. So all of the neurons in the visual cortex are saying it's dark, it's dark, it's dark, it's dark. They're saying the same thing, and so their activity synchronizes, and you see this nice visual cortical activity. And because the subject is in a shielded room, the detector was able to see the field produced by this brain activity. So that's the basis of MEG recording. This was the very first study done. So not only do we have to consider making sure that external fields aren't affecting recording, it turns out that we're also limited because there are artifacts everywhere. A heartbeat creates an artifact that's much bigger than brainwave activity. Eye blinking, clenching jaw muscles, electronics in the lab, they all create noise in our signal. So there are a lot of engineering challenges in the lab, and most MEG labs have bioengineers on staff that work very closely with the clinical staff to try to reduce these artifacts. And so it's not always easy to acquire the data. So why bother? Why do we do this? It's similar to EEG. It's kind of difficult to get. What are the benefits versus EEG? Why is your doctor suggesting you get this test? How can it help? So there are several benefits, and I alluded to them. The fact that we're looking at magnetic fields and not electrical current actually does make a difference. So there are a couple of ways that MEG can help. One is that we have better spatial resolution. So what do I mean by that? This one is pretty simple. It's just a numbers game. The MEG helmet, the part that fits over your head and has these squids in it, has many more sensors in it. Depends on the system. It can have anywhere from 160 to 300 sensors. So we might have 10 times as many sensors, as many detectors as your typical EEG array. So I'm just showing here an EEG electrode diagram with the dots representing where we usually put EEG electrodes. And then these are two typical MEG sensor arrays showing where the MEG sensors typically live outside of the skull. So that's sort of a simple advantage. Second advantage is better bandwidth. So what do I mean by bandwidth? So we've talked about this a little bit, but brainwaves are signals from the brain, and just like any other signal, like light or like sound, we can group signals depending on their frequency. And for brainwaves, this is as an aside, we tend to group things based on their frequency. We sort of analyze them and speak about them in these categories based on how many wiggles you get per second. So you heard me talking about alpha before. And I guess what I would say is, imagine if you were trying to listen to music wearing earmuffs. You don't hear high frequencies very well. And then you take off the earmuffs and you can really hear the richness of the sound. So the way I would put it is that the skull can act like earmuffs. You lose some of the EEG signal. You're only looking at certain frequency bands. You're only looking at maybe at these frequency bands, but you're losing these fast frequencies. But because MEG looks at magnetic field, the field passes right through the skull and you can see these faster frequencies. so you can see more of the information that the brain is putting out. So when I say that MEG has better bandwidth, that's what I mean. We can see more of the rich frequencies in the brain activity. So better spatial resolution and better bandwidth. And then the other advantage that I think is pretty important is that it's easier to do what we call source modeling. So what's source modeling? So once you've recorded signal, and you can do this with EEG or MEG. Once you've recorded brain waves, you then have to figure out where in the brain it came from. And this is called source modeling. So my husband sent me this video of our dog. He said, remember, it's important to know the source. So I'm going to see if I can play this. Let me see if it'll work. It may not. There we go. So she couldn't figure out the source, so she couldn't track the trajectory of the bone. So you need to figure out where it came from. And so this is called source modeling. Let me show the next slide here. The concept here is you select something in the brainwave that you would like to know where it came from. In this case, it's a spike. So you have this abnormal discharge of synchronous neuronal firing, and you say, hey, I wonder where that came from in the brain. That might help us to plan surgery because seizures might be coming from where that person's spikes are coming from. So basically, you pick an event and you ask the computer to tell you, if I had to account for all of the signal in one spot in the brain, where would you put that? And the computer will propose some models. And then we can go through the models and test them and select which models we think are plausible or not. So that's when we say magnetic source imaging or source modeling, that's what we're talking about. So it turns out that it's easier to do source modeling with MEG than with EEG. And again, it relates to the fact that we're looking at magnetic fields which pass through the skull, the scalp, the brain without distortion. For EEG, you have to account for all of the different layers of the brain and the scalp and the skull and make what's called a head model so that you understand how the fields are affected by all of the different compartments when you do your source model. So it's kind of difficult to record the MEG. It's much more difficult to get the equipment lined up and everything just right. But once you've obtained the signal, it can be somewhat easier to analyze it and to obtain a source model that you can then use to do your pre-surgical planning. So those are the benefits. When it comes to planning surgery, MEG can tell us more easily what part of the brain might be responsible for abnormal activity. And we can also do functional mapping with MEG. So we can identify regions that might be nearby a source of abnormal activity, regions like hand sensation or hearing regions or language function. What side of the brain do you use to talk with, to read with? So we can do functional brain mapping to help with preoperative planning as well. So those are some of the benefits or advantages versus EEG. But it really is a complementary sister technique to EEG. By the way, I thought it was pretty cool that back in 1944, the Baron Adrian, who had received the Nobel Prize for Physiology in 1932, was already complaining a little bit. EEG was in its infancy, and he was saying, with present methods, the skull and the scalp are too much in the way, and we need some new physical method to read through them. In these days, we may look with some confidence to the physicists to produce such an instrument, for it's just the sort of thing they can do. So it took them a while, but he was already frustrated with the fact that EEG had these physical limits. So he sort of previewed the existence of MEG many years prior to its introduction. So I thought that was interesting to find that. So just zooming out, and I'm sure this group needs no introduction, and you've been talking about this today already, but the problem is that we need to figure out whether better tools would help increase the availability of epilepsy surgery to those who would benefit from it. We have many people in the US with epilepsy, and despite more new anti-seizure drugs every day, it's not clear that the percent of people who drugs are not helping is diminishing. So it seems like the same 1 in 3 continue to experience seizures. And despite, over my career since I was a fellow, we've had many publications illustrating that it's important to at least consider the option of epilepsy surgery. An average patient tries 7 different medicines and may wait up to 20 years before even considering surgery. So as an epileptologist and as an MEG-er, I have to ask, would it help to have better tools? Can MEG help? So that's what motivates me a lot when I think about this, when I think about MEG. And you've likely already talked a little bit about this, but this is sort of our case conference eye view when we think about surgery. We have these 2 goals. One is to try to figure out where are the seizures coming from? Can we find this area where we think the seizures are coming from that may or may not be a lesion on the MRI, but we think that there is a region or a network that if it were removed could potentially be both necessary and sufficient to stop the seizures. So that's one I've shown it as a scale. So that's one arm of the scale. And the other arm is, can we preserve function? Because we wouldn't propose a surgery that would be dangerous to function. But we know that someone's brain map varies, right? Everybody's brain map looks a little bit different. And then it probably changes even more with development, growth and development of the brain. And then if you have a brain lesion or if you have ongoing spiking in an area, the functions may choose to remodel in a slightly different area. So that map needs to be recast for everybody. Each person needs to have their own individual mapping done. So that's the other arm of the balance. So those are sort of the 2 goals that we have to meet when we're planning seizure surgery. And so MEG really can help us with both arms of these equation. MEG can help us to locate potential sources of seizure activity and can fairly early on in the pre-surgical evaluation give doctors an idea if someone could potentially be a candidate for surgery. And then once evaluation is underway, MEG can add, for example, if somebody has an MRI and it shows a lesion, an area that the doctor thinks may be abnormal, like a cortical malformation, for example, but the EEG doesn't seem to agree. So the EEG shows abnormal activity in a slightly different area, or maybe the EEG shows this broad pattern, but nothing too specific. And so there's a little bit of what we call discordance, or just not enough information to really nail down a plan. MEG can do what's called corroborate, which means just add some additional weight to the plan to enable a plan to be made. Another time when MEG is really helpful is when someone's already had surgery. Often people will have several surgeries, or they might have had, for example, a tumor, another type of brain surgery, and have residual seizures. So a reoperation is considered, But in that case, sometimes the EEG is very difficult to interpret. There's a lot of artifact there. So in that case, MEG can also be very helpful because magnetic fields are not distorted by the changes to the shape of the skull. And you might not be surprised when I say that based on what I've said before about the different physics involved. So that can be another way in which MEG is really helpful. And often, as you probably heard already, MEG can also help with the placement of IC or intracranial EEG, by which I mean stereo EEG, as well as subdural grid electrodes or strip electrodes. Often the team may have a hypothesis for some coverage, but may not be exactly sure what areas should be covered. And MEG can really help to narrow that, either help position the grid or help specify the exact trajectory or number of stereo EEG electrodes. So that's another very common use of MEG. And as I already mentioned briefly, of course, we also do functional mapping. So we may map, for example, hand sensation or motor. We may map visual function, hearing, and we may also establish language dominance. In other words, what side of the brain you use to talk. So in that way, we're able to offer that side of the equation, also the functional map during pre-surgical planning. So today, I'm not going to go in great depth into the evidence for MEG in epilepsy surgery. This is not a situation where we have randomized controlled trials, where we offered some people MEG and we offered other people no MEG. That's not thought to be ethically possible, but I think some of the very best work was done retrospectively, where people already had the MEG done, and then they had the doctors make a surgical plan for a patient, had them draw a map of what they proposed without revealing the MEG results, and then after revealing the MEG results, and saw whether whether MEG changed the decision making. And so I think those studies were very useful because they showed how much MEG could help. So that's some of the best evidence that we have for MEG's usefulness. And then the other big sort of collection of studies that have been done on MEG have mainly been outcome studies. So large series of, one was of 400 and one was of 1,000 patients who had had MEG and gone on to surgery, and then looking at the pattern of MEG findings and people's outcomes. So those are the sort of the two main streams of evidence that we've had. And then the other useful publication record we have with regard to MEG has been case series of how MEG has been used in very specific syndromes or clinical scenarios. So, for example, I've mentioned reoperation. There have been a large number of publications, for example, on entities like tuberous sclerosis and MEG. So many specific epilepsy syndromes or surgical dilemmas, epilepsy surgical problems or clinical scenarios have been studied in case series over the years. So I have a lot more to say about the literature, and if anyone's interested, I'm happy to talk with you offline about that. So just turning now to what to expect. I've been with our lab since 2004, and our activity is almost evenly divided between research and clinical scanning. And then our clinical studies are about half epilepsy and half tumor. So we may do anywhere from 2 to 5 epilepsy scans per week. And we see patients from UCSF, but also throughout the western half of the United States. So we see many people from all over. And we have a very experienced staff who I'm very fortunate to work with. They've been with us for a long time. And they love to, if you end up coming to our lab, they love to talk to you beforehand to plan your visit. And I would just encourage you, before you get to your appointment, to call ahead and to talk about how we can make this a good experience for you. I think in general, it's important to know that you should avoid bringing anything with metal with you to the lab. So please leave at home any clothing with metal, any jewelry. If you have removable dental work, take it out if you can. Please don't wear any makeup. Even like eyeshadow can have metallic particles in it. If you have lash extensions, if you don't mind removing them, that would be great. Even hairspray can create artifacts, so it can be surprising. But if you can remove whatever you can remove, it would really help in terms of reducing artifact. And then in terms of medical implants, the only thing that we really can't have you come in with, unfortunately, is cochlear implants, because they contain a magnet as part of the way that they work. They contain a magnet. Most other equipment, it depends on the model. So just check with us and see what we can do. Please wear comfortable clothes that you could sleep in. And you want to talk to your referring doctor about whether they want you to be sleep deprived and whether or not you should skip any of your medications. Unlikely that they'll want you to skip seizure medicines, but you can talk with them about it. And if you're bringing kids in, talk with us about what you can do to prepare them. We have, done, right now physical tours are not possible because of COVID, but we've done video tours and we've worked with Child Life to sort of prepare kids about what they might expect and to sort of walk them through how it might look. So feel free to reach out and talk to the lab. I would say that any lab, we're a small community, and I think safe to say any lab that I know of in the country sort of runs very similarly as far as having a lot of communication with people coming in. Once you're in the lab, you'll either remove all clothing that might have metal or change it to a gown if it's more comfortable. And you will have EEG electrodes placed along with some small location coils also taped to your head. And a technologist will mark the positions using a small device that helps us produce the source localization later on. And then you'll just rest on the MEG bed with your head in the doer, and I'll show a picture of that next. And they will shut the door to the magnetically shielded room, but you'll have a microphone so that you can communicate with the technologist at all times. So you'll be talking back and forth. And then the test itself takes about 2 hours, but you can rest during most of it, except at the very end, if you'll be doing any functional mapping, you may be shown pictures or played sounds, asked to respond to some questions, or you might have some small stimulating equipment attached to your hands and feet. So depending on what's been ordered. And then after the test, we do the analysis, and we typically will communicate directly with whichever doctor ordered the test, whether that was your epileptologist or your neurosurgeon. So that's where you would communicate to get the results. And this is our lab. You can see this is the bed. It does convert to a chair, but we found that as people get sleepy, they tend to kind of slump down out of the helmet. So it's just easier, if it's comfortable, if they can lay down with their head in the doer here. So that's how people generally are positioned. And we may pad this, especially if somebody with a small head, to help their head stay in the middle. And then you can kind of get a feel for the size of the room. So it's typically not very claustrophobic. It's a small room, but you've got plenty of room, unlike an MRI. And then this picture just shows those head position coils that I'm talking about, taped to one of our grad students' face there. And I just wanted to show a picture of some other MEG systems. They all look fairly similar in this setup, but there are some differences as far as exactly how the bed works, and of course upholstery color. But most all of them have similar setups where you put your head in sort of a concavity or a depression where your head might fit, kind of like a very old-fashioned hair dryer, if anyone remembers those. So just to wrap up, where are we headed? I think a lot of our work in the lab, and especially with the overall lab director, who's a neuroscientist and a bioengineer, Dr. Nagarajan, we're engaged in developing and testing a lot of new algorithms, mainly for improved localization of abnormal activity, as well as for mapping. And one of my goals is that we have better biomarkers for the seizure network so that we can target it better and decrease the use of invasive electrodes. Also, so that we can understand the relationship of sleep to epilepsy, and so that we can have better predictors of surgery outcome. If MEG could help us predict chances of surgery success, I think that in itself might be pretty useful going in, just to give some degree of better guidance when you're trying to plan and think about options. And then the other work that we're excited about is to have better understanding about the cognitive effects of epilepsy. How does epilepsy affect the functional brain activity? Can this understanding help us to tailor resections in the future? Could it help us work toward targeted cognitive therapy related to deficits in, for example, verbal memory that people have? So these are some of the questions that we're very interested in the lab. And I'll just show a couple of images to illustrate. For example, this is a young woman who had very frequent seizures, something like 9 seizures a day involving her left face, tingling and twitching. And unfortunately, her EEG didn't show much of anything. It was, she had some slowing in that area, but nothing focal enough to plan a surgery. And she came into the lab and she had some very tiny spikes that we could only see on MEG. And we were able to map them. And so we did source localization, and these little yellow dots are where we found them. And they were where you might expect based on her seizure type. They were in a region very, very near to the region where you might expect mouth sensation and motor functions to be. But we were also fortunate to catch a seizure. So she had a seizure while she was in the scanner. Not fortunate for her, but it was very useful. And we were able to apply some of our new analysis methods to map the beginning of the seizure, which was not typical. It was not these high amplitude goal spikes. It was this very subtle, fast activity that again would be filtered out on a scalp EEG, but we could see that fast activity on MEG because it detects that magnetic field, and even fast activity can be seen on MEG. So we were able to localize the seizure onset, and you can see the red dot right there. I don't know if you can see that, but it's right near my red laser pointer dot. So we're able to really pinpoint where her seizure started. That was very useful in helping guide her therapy going forward. So that's an example of an algorithm that was developed and now is coming to clinical use in the lab. So that was exciting for me as an epileptologist. And then the other, this is really new work. We have a team with us that's looking at functional connectivity. So how information is flowing between different brain regions. And we're comparing the information flow in people with temporal lobe epilepsy and people without. And we're seeing that there are changes in information flow patterns in certain frequency bands in people with epilepsy. So that to us is very interesting. And we're seeing that some of those changes correlate or track with clinical variables such as the length of time somebody's had epilepsy, and the frequency that they're having spikes on their EEG. So this is very early work that we've just started, and I hope to be able to show you more of this later as we complete it or refine it, but just a window into the sorts of things that we're developing. It's very similar to a lot of things that are hot topics in the MEG community. I'm hopeful that in time we're able to better help teams better plan intracranial, and even maybe supplant or replace some of the intracranial techniques that we've used for surgical planning up until now. So that would be a dream, I think, for us all. Just to sum up, I think, MEG really gives us this great window into brain activity. We have really good time resolution, pretty good spatial resolution, and the ability to see this broad range of frequencies, all of the beautiful brain activity that we can see. And if we can figure out how to analyze it properly, we really get this unique and complementary set of information to help us plan epilepsy surgery. So we would be happy to help your team if you need MEG. And if you have any questions, talk to your team and to the team at the MEG scan site about how best to prepare. And we're also really excited to expand ongoing analysis techniques for insight into brain activity, including in people with epilepsy. So I am going to pause here, and I want to thank you. I want to say I got a copy. I don't know if anyone here was involved in this fantastic book that I've been reading that's just blown me away with stories of epilepsy. And just on the side note, I've also been privileged to be doing telemedicine during COVID, and being able to do telemedicine with people in their homes has really been wonderful, because I feel like this has given me the opportunity to do home visits in a new way. So on a personal note, I just feel very grateful to hear so much about epilepsy and seizures and life from people, both through this book and over the last many months. And so I just want to say thank you for having me, and thank you for sharing your stories. Anyhow, I'll pause and take questions. Yes, I see a hand raised from John Michael.
Am I live here?
Yes.
Oh, I actually wrote it down here. I'll just read it to you.
Yes.
I'm going this week into an epilepsy center for refractory epilepsy. I was just saying, if a MEG is suggested, I feel like it would be a privilege to have one. It's very cool. I think it's so futuristic, I would almost expect to see it on Star Trek Next Generation. Anyway, one of my questions is, I have had a heart operation, and I don't know, is there enough metal down there to be a problem if this is offered to me?
No, it shouldn't be. Let the people know, but we do have ways of reducing artifact. Generally, metal does cause artifact, and what it does is it causes this like big slow wave. And we do have algorithms that can denoise it. We ask that we reduce it as much as possible as people come in the door, but if it's not possible, it's not possible. So we have ways of cleaning the data afterward. Yeah, and that's the kind of thing that we can usually clean. And then we have other ways of dealing with that. Like we pick something out and then we average it to increase the signal to noise ratio. So there are tricks for dealing with it, but I would say the best thing to do is just let the lab know in advance so that they can brainstorm about it. Strange things come up all the time, and so most labs have sort of a set of workarounds. So just let them know.
Yeah. One quick thing, since you've got me. So any advice to somebody who's going into an epilepsy center for the first time?
Yeah, I would say it's useful for me if you're able, and if you're not, it's fine, but if you're able to bring like your physical, like if you've had like past EEGs and MRIs, like the actual EEG, like on disc. And then it's great if you have, and if you don't, again, it's okay, but if you have a list of like medicines you've tried. But generally, I want to hear everything else from you, especially personally, I really like to hear, as difficult as it can be, but really what your seizures are like, either from you or from someone who's seen them if you don't know, in pretty, in a lot of detail. And I apologize, I always apologize if that's, you know, hard to talk about, but sometimes what happens is, with all medical problems, things just get propagated in the record. Oh, this person has blah, blah, blah type of seizures. And then, you know, it's always useful to take a big step back when you see someone new and to say, well, wait a minute, let's just start at the beginning, because sometimes there's been some assumption or something that's just sort of propagated itself. So I would say be prepared just for some things to feel maybe redundant. So the intent is not to waste your time, but sometimes, especially for specific things, like I want to really understand what it feels like to have your seizure, if that makes sense. So that would be my other thing, is just be prepared for some things to be repeats. I don't know if that's useful.
Yeah, they'll probably be sorry they asked me. I have a lot, a lot of, I even have videos of it now. So
yeah,
let someone else talk. I really appreciate it. Thank you.
Sure, my pleasure. Thanks for tuning in. Let's see. Let me take a look at the chat here. Okay, so I have from Melissa, does the MEG results looks at the EEG results like the MRI? Yeah, actually, we always, and I think most labs do an EEG at the exact same time. And I look at the EEG along with the MEG. It's really important. That's a really good question, because they are perpendicular, literally perpendicular. So if you see a spike on the EEG, you sometimes, a lot of times, you also see it on the MEG. It sometimes has a slightly different shape, and sometimes you see it on one first. You may see it on the EEG first or the MEG first. And that fact can help you tell where it's coming from, because the brain is very foldy, like the brain has lots of folds in it. So sometimes a spike will show up sort of in a funny direction that you pick up on one first versus the other. And so it's really helpful to have both at the same time, even though MEG has its advantages compared to EEG. We always do EEG, number one. And number two, we've been doing EEG since the 1940s. So I read EEG every day. I'm very familiar with it. And sometimes there are funny looking things on MEG. And we only have, you know, I've only been reading MEG since 2004. And we as a community have only been doing lots of clinical MEG for so many years. So, you know, it's always useful when we see something strange to look at EEG also and try to, you know, corroborate the two modalities. So I think it's essential, I guess, is long story short. If you really can't do a good epilepsy MEG without doing EEG at the same time. I feel pretty strongly about that. So that's a very good question. Let's see. Oh, yeah, this is a really good question. We did 2 MEGs for 7 hours and nothing has shown up on MEG. And EMU also, nothing. So this is really difficult. And so, you know, it's hard to know now without knowing your son's specific case. You know, it depends if there's enough information in sort of how the seizure, the story of what we call the semiology, which is like the signs and symptoms that he experiences and that you've noticed during the seizure. Is there enough information there to even have a hypothesis going on? And has there been anything on the EEG? So it's kind of hard to know. Has there been any clue, or has there been sort of, we don't know where this is coming from in the brain? So it's hard for me to know where I would go with that.
Dr. Kirsch, this is
yeah.
Brad. I'm chiming in because I know that family who just asked you that question. I know
Yeah.
that young man very well. I
Yeah.
would love to email you his issues as well. I'll
Yeah.
get mom to chime in. We'll send you an email this week.
Fantastic.
And
Yeah,
I know we can get you his imaging and data too.
I'd be so happy to go into that. That's
And
a
Mark's
really good
parents would
question.
love to hear that too.
Yeah, yeah.
Thank you.
Good.
I don't know if
course.
you can hear me.
I can
I
hear you.
can. Thank you. Thank you for the
Okay.
Why,
question.
thank you so much, Brad.
Of course.
Yeah, thank you.
May I just add a
Yes.
tiny, small bit of history to this?
Yes.
Our son had a VNS, and when we arrived at your clinic, it was turned off, and the conclusion was there was too much artifact to get any useful information. So we went home, and he subsequently had the generator of the VNS removed, but the coil and wire are still in place. And we repeated the study, but it yielded no additional
Oh, man.
results.
Okay. So
So
despite
that's
that.
where we are.
Oh, okay.
That's why I'm saying he's complicated.
Yeah,
I'd love to
yeah.
get you the whole portfolio.
Okay.
Thank you, thank you, thank you.
Sure. My
Okay.
pleasure. My pleasure. And then I see one question on differences in strength of MEG as there is with MRI. The answer to that is no, because with MRI, the Tesla has to do with actually the field the MRI magnet is producing, right? So the stronger the magnet, the better the picture, up to a point. And I don't understand MRI physics, but when you get up to 7T, I know it's better for some things, but it's not as good for other things. And I know it can also make you, or the early ones made people vertiginous. So I know when you get up around from 3T is fabulous, 7T, I don't know a lot about the benefit of going from 3 to 7. So I don't know a lot about MRI, but with the answer for MEG is no, because we don't have a magnet in it. We are just listening. So we don't, but that said, there are a lot of differences in the scanners, right? So they have different number of sensors, they have different sensor design. The different manufacturers each feel strongly that their design is superior. From the reader's end, it's all good. Like it's all good. We can work with any of it. I have to say very, very, I think it's all great. And we can work with any of the sensor data that comes in. I think the software tools are kind of a big deal. I would rather have better analysis tools. I think the hardware is all pretty good at this point. I do think that there's a lot of work being done on room temperature, MEG, wearable MEG. That's exciting because if you aren't aware, and this is kind of a trivial fact, there's a shortage of helium. So it's very expensive and there isn't much. So it's used for a lot of industrial applications. And so that's a big problem for MEG labs, just keeping the squids cold. So
Doc, I hate to cut you off. I
Yeah,
have
no
Dr.
problem.
David Adelson waiting to start his presentation.
fantastic. Okay.
I'm sure you know him. But thank you so much. And I will definitely
My
connect you
pleasure.
with the 2 patients in the week. This
Fantastic.
week.
Thank
Really nice to
you.
have you, Doc. Thank you.
Likewise. Take care. Bye-bye.